started. But now I would love to welcome Patrick Devereux, PharmD, and and CEO of Happier at Home in Birmingham. And he'll be presenting medication safety and caregiving. And today's presentation will focus on the importance of proper medication management and adherence, particularly in regard to long-term caregiving. So this is a very important topic, and we're so glad that Patrick's able to join us today. A little bit about Patrick. He has been a pharmacist in Birmingham, the Birmingham area, for about 17 years. And his passion is helping patients understand their medicine better, making sure patients have the vaccinations they're needed and have the tools needed to take their medicine. He's also passionate about working with patients and families after a hospital discharge to keep them healthy and at home. So we are very excited to hear from Patrick, and I'm going to turn it over to you now, Patrick. Thanks.
Thank you so much. Really excited about talking about this. Is an area I'm very passionate about. Actually, my venture into the home care side and owning a home care business is very new. Just did that this year. But I'm a practicing pharmacist still daily. And the president of Family Medical Services. We own 4 retail pharmacies in the Birmingham area. But medication safety is just a passionate topic of mine. It's kind of an all-encompassing definition. So I've got some stuff prepared that I'd like to talk through, but I really want this to be as interactive as possible. So please feel free to stop me. I'll keep an eye on the chat for any Q&A. If it's not something you necessarily want to ask out loud, type it in. I'll be happy to try to address it with the whole group. Really, I think in terms of caregiving and what I deal with on the caregiving, but also on the pharmacy side, as I know you do as well, is that medications are just can be very overwhelming. Just the whole thing, just in general, taking medicines, managing medicines, knowing, did I take it? Did I not take it? Did I take too much? Did I not take enough? All of that is so important. And I think sometimes in practice, we as pharmacists take it for granted that everyone has a good understanding of medicines, and really and truly, do the caregivers have a good understanding of medicine and proper medication management? So we'll talk through all of this today. Hopefully you guys can, I'm going to go ahead and start the show here. So hopefully my screen is still visible. That's me. So a little bit about our company, we'll keep that pretty brief, but we are an in-home caregiving service. We have a particular focus on medication management. There's only a handful of companies in the state that are owned by a pharmacist. And so we do put a very special emphasis on medication management, but really and truly, we want the same things that you guys want. We want our beloved patients to stay as independent in the home and to age in place as long as possible. Without having to necessarily transition to other areas of care. So our company focuses on providing tools and resources to do that through the in-home caregiving that many other companies do, but we do provide a pretty special emphasis on medications, on medication management, reminders, tools and resources, that kind of thing. And our purpose is we want to support independence, keep people at home, and enrich their lives. So let's talk through medication safety is where we're going to start with. And again, that's kind of an all-encompassing definition. Medication safety basically goes to all aspects of taking medication. So we're going to cover all of these things today. Medication adherence, how adherent are you? How compliant are you with taking your medicine daily? Medication overuse, medication underuse, and where we'll probably spend the most time today is medication selection based on patient age and physical condition. So as caregivers, it is so important to know what are some of the medications. And most prescribers do know this, but some don't. Some do not take this into consideration, but we're gonna talk through some of the medications that are really not designed to be used in the elderly. We're going to talk a little bit about the Beers criteria, if that's not something you've heard of before. I'm really glad that I can talk through this with you today, as it is a very, very passionate area of mine, making sure that patients are not on medicines that can cause long-term harm, especially in the elderly. So let's talk about taking age and physical condition into account. So I want to spend some time here and make sure that everybody understands, and most of you I'm sure do, but we don't respond to medicines the same way at age 41, I'm 41, that we would at age 81. There's a lot of physiological changes that happen inside the body with regards to how our kidneys work, how our plasma proteins work. And what that means is where medications can bind to certain proteins in the system, that changes over time. And so a lot of times as we get older, medications that we could tolerate in our 40s, we cannot tolerate the same way in our 80s. And still, so even certain medicines that we're going to talk through that could be considered pretty mild, but again, with just a small change in the physiologic function of the body, those medications could have a tremendously different effect in someone who is older. And so the way we react to medicine changes over time, and with the addition or subtraction of other prescriptions. This is an important point too. So when we talk about drug interactions, we don't necessarily always mean that it's unsafe to take two medicines together, but sometimes those medicines can affect the levels of other medicines. So for example, certain cholesterol medicines, based on the enzymes that metabolize them, they can affect the levels of antibiotics or vice versa. They can affect the levels of blood thinners and things like that. So there's a lot of things to take into account. Again, they may not always be harmful, but if you add or subtract one of those medicines, all of a sudden the level of medicine in the body can change. And so that's drug interactions. But a lot of times I think when we think of drug interactions, we think of a negative effect or negative outcome of drug interactions. But we're talking about just regular medicines that impact the levels. And if you've got I'm hoping all of you have a great relationship with your local pharmacist. Please seek out a good, trusted local pharmacist, whether they're in a chain pharmacy or an independent pharmacy. I'm a little biased, and I think everybody should go to a locally owned pharmacy. And if you tell me what town you're in, I can probably tell you the best independent pharmacy to go to if you're in Alabama. But again, it's taking all of these things into account and constantly consulting with the pharmacist, especially when a medication is added or subtracted. So because of physical changes, older adults are more sensitive to certain prescriptions. So something as simple as may cause drowsiness or dizziness in someone in their 40s, in a younger adult could be amplified and even cause falls in older adults. Again, it all goes back to that physiologic change that we had before, related to the kidneys or related to things like plasma proteins in the blood and how those medicines bind to those proteins. And forgive me, I'm just going to keep an eye on the chat just to be sure that any questions come in there. So I will move this over here. All right, good.
And I'll help you with that too, Patrick. I'm
Okay,
keeping an eye on it.
Great. All right, so we're going to talk about something called the Beers list. And some of you may have heard of this list before, and I don't want you to think this is the only medicines that the elderly can't necessarily tolerate. Sorry, older adults. I'm trying to get out of, I don't like to say elderly, older adults. I'm retraining my vocabulary there. But developed by the American Geriatric Society. This is a tremendously great resource. And I just took this from their website, but this basically talks about what the Beers criteria is. A comprehensive list of medicines older people should potentially avoid or consider using with caution because they often present unnecessary risks for this population. Now, when we were in school, I think most of us as pharmacists associated the Beers list with medications that increase the risk for falls. But as you're going to see here in a little bit, when we talk about certain medicines, it's not just fall risk. It's just other medicines that older adults are more sensitive to, especially with long-term use. And so we'll talk through that. But falls and fall risk obviously has to be a tremendous focus, probably our main focus when it comes to medication safety. But there are some other things that may or may not contribute to a fall that do cause some problems in the elderly that we'll talk through from the Beers list. And this is a very easily accessible list. The list isn't necessarily the list has certain drugs on there, but on the website, it mainly groups into classes of medicines that we want to try to avoid in the elderly. So, but it's not all of the medicines within those classes, but we'll talk through some of that. So first thing, examples of Beers drugs. First generation antihistamines. What does that mean? First generation antihistamines are drugs like Benadryl and chlortrimeton and medicines like it. They do not include Claritin and Zyrtec and things like that. Those are not first generation antihistamines, so they don't have that drowsiness and dizziness effect that first generation antihistamines do. So we really want to use caution, and this is always at the top of the Beers list. if someone who is taking Benadryl, and this includes, and this is the part that our clients and our patients at the pharmacy don't like to hear, first generation antihistamines includes Tylenol PM. Many don't realize that Tylenol PM is simply Tylenol and Benadryl combined in one capsule. And so while it may cause drowsiness in someone who's younger, that drowsiness lingers and can cause some dizziness the next day even, and a fall risk. So first generation antihistamines, we really want to try to avoid those in our patients who are older, and try to focus on using safer antihistamines. Again, there's still some risk with these too, but not as much risk as the first generation. So as opposed to using Benadryl or chlortrimeton or some of those over-the-counter products, NyQuil unfortunately has a lot of that in there too. Doxylamine, which is in NyQuil, is a nasty one. Really can make you very drowsy and could fall the next day. So focus on for runny nose type symptoms. We want to focus on Zyrtec and Claritin and Allegra. Those are not first generation antihistamines and definitely can cause less drowsiness. Muscle relaxers. This is tough because our older adults are a lot of times struggling with chronic pain and things like that. And certain muscle relaxers are definitely not safe. There's the two that they're still not 100% safe, but they're safer, are drugs called tizanidine and methocarbamol. Those are typically a little safer than your other muscle relaxers like Flexeril, Scalaxin, and I'm using brand names. You may see the generic names. So also, if you've ever been to the pharmacy for you or for a loved one, and you've got Medicare and you've tried to get a muscle relaxer filled, and that plan said, that drug is not covered. Sometimes that means that drug is on the Beers criteria or is not safe in the elderly. And they may cover a safer alternative as a muscle relaxer like tizanidine, or I'm sorry, I said methocarbamol. I meant tizanidine and baclofen. Those are your safer ones in the older adults. Certain medicines used for anxiety and insomnia, for example, using Valium, which isn't as common anymore, but using Valium in older adults. Valium has some nasty metabolites. What that means is after it's done working in the system, normally, and again, normal younger adults, we take it and our body we use it and excrete it and just get it right out. But in older adults, those metabolites of Valium kind of hang around a little bit longer and last longer than someone who is younger. And so that can cause some lingering drowsiness, lingering things, lingering drowsiness and dizziness, things like that. You may have heard stories of Ambien, which is an insomnia medicine, is also one of those that hangs around a little too. It's not, I don't know if it's specifically on the Beers list, but I will say that Ambien is kind of a nasty one when it comes to how long it can linger, especially in women for some reason. 5 milligrams, 10 milligrams in women, it really is actually really need to be try to use 5 milligrams, especially in older women, because that medicine, for some reason, they don't clear it the same way. You've probably heard stories or seen news reports of people getting up and, I don't know, baking a cake on Ambien and not remembering, or driving to the store and not remembering. Those are things that are very real side effects of Ambien. And so Ambien and medicines like it, like Valium and things like that, the most important thing, I think, and this is tough because I know a lot of you see this, is trying to only use those medicines when needed. So unlike other medicines that we're going to talk about later that have to stay at a certain level in the body, those medicines are mostly as needed medicines. But the more chronically you use them, those medicines can build up and cause some of these lingering effects that we're talking about. So short-term use is very important whenever possible on any of the medicines we're talking about, even if they're safer alternatives, to keep that risk for falls and other problems down. Certain diabetic medicines. Let's talk about that for a second. Why would certain diabetic medicines be in this? And these are medicines that are not as commonly used anymore. The drug class is called sulfonylureas. So drugs like glipizide, glyburide, medicines like that, they're not as common anymore. We do see them, but not as commonly. So when I was first coming up in practice, one of the biggest diabetic medicines was an extended release form of glipizide. And what that means is for extended release medicines, you just take it once a day and you're done for the day. But those especially have been found to be problems in the elderly that are glipizide and glyburide long acting because of our kidney function that we talked about changing. All of a sudden, these diabetic medicines are staying in the system longer and keeping the blood sugar lower longer, and possibly even bottoming the blood sugar out at times where we don't want it to. So they've really fallen out of favor. I'll be honest with you. I think I may have one patient left on the extended release forms of glipizide. Maybe not even that anymore. They've really not been, with all these new medicines we have now, both injectable and non-injectable. They're not very commonly used. But some doctors still like to use them. Now, this is not metformin, or those are perfectly fine in terms of risk for patients. I do think they need to, monitor their kidneys and things like that, but they're not going to bottom the blood sugar out like the medicines I'm talking about. So if you've gone to fill a certain diabetic medicine, especially one like that that's older and generic and pretty cheap, it's possible that the Medicare plan is stopping that from being filled, so that it keeps the patient's risk for bottoming their blood sugar out low. Antipsychotics. So these are drugs that, like olanzapine, quetiapine, risperidone, these are sometimes used for sleep, but in older adults, we do not want to use those medicines unless they're being treated for active psychosis or hallucinations or things like that. Sometimes if it's used for insomnia or dementia, the risk for adverse effects, the risk for stroke, those things actually increase in older adults. And that's actually been a big problem in nursing homes. Many of my colleagues who've gone into nursing homes to consult as part of the nursing home pharmacy, they look for things like inappropriate medication use in the older adults. And one of those is, okay, is there a clear indication for this medicine, antipsychotic medicine? Is there a diagnosis of psychosis or hallucinations or things like that only this medicine will work on? But sometimes there's not. Sometimes it's just being used for insomnia, or being used to add in with depression, or those types of things, or just dementia in general. That's not a good idea. So those need to be used with caution. Drugs that are called anticholinergic drugs, not as common anymore. I would think the most common out of these that we see is probably amitriptyline, but dicyclamine, amitriptyline, imipramine, trihexyphenidyl, not very. These are old drugs. They're good drugs in folks that are not older, but these drugs do tremendously increase the risk for falls. Anticholinergic drugs can cause a lot of dizziness, especially upon standing. And so those are medications that we need to be mindful of. And again, short-term use sometimes is okay, but monitoring for those risks is also very important. Hormone replacement. This is interesting. We do see some, hormone replacement can cause adverse effects in the older adults, mainly related to heart attack and stroke risk. So a lot of times we try to be as conservative as possible when trying to manage postmenopausal symptoms with hormone replacement, but at the same time balancing out the risk profile for everybody. We don't want anyone to have to necessarily live with those symptoms, but typically, we have to balance the risk with the hormone replacement. But when I first started my career in Florida in high school, and everybody was on hormone replacement down there. Everybody was on Premarin and estradiol and all of these medicines. And we don't see it as much anymore once you pass a certain age. So they've really fallen out of favor. Digoxin, honestly, I was making this remark to someone the other day. Digoxin is a medication used for heart failure. Not very common. And when we do see it, we do see a lower dose being used that keeps there's no benefit. There's actually more harm than good if you use the higher doses of digoxin for heart failure. Honestly, though, there's so many medicines now for heart failure, digoxin's not used as much. But higher doses of digoxin, meaning 0.25 milligrams or higher, 0.125 is the typical dose of digoxin, but sometimes we see a higher dose, but honestly, just do not see it. Again, when I was in Florida, I feel like everybody was on digoxin in my community, but we really don't see it as much anymore. And then lastly, what's also on the list is long-term use of NSAIDs. This is really important. NSAIDs, non-steroidal anti-inflammatory drugs. So drugs like meloxicam, Celebrex, or the generic name is celecoxib, naproxen, all of those have risks. And the risk on the NSAID side for patients who are older is twofold. One, older adults are much more likely to get GI bleeding, stomach ulcers from NSAIDs than are younger adults. And going back to what we talked about before, it's because those medicines hang out in the body longer and they don't get eliminated as fast. So the risk of having a GI bleed or an ulcer in someone who is younger is still a risk, but that risk is amplified in our older adults because of how our body clears those medicines. Also, it's been found, I think some of you may be old enough to remember a drug called Vioxx. That was out when I was in pharmacy school. It got pulled off the market actually before I graduated, and it was a very good medicine. But what happened there is they found that one of the long-term effects, especially in our older adults, was cardiovascular risk and stroke, which is interesting because a lot of times we use aspirin for prevention of cardiovascular risk and stroke, and aspirin is a NSAID. But most of the time when we use aspirin, we are using a very conservative dose, 81 milligrams or so. We don't see very much 325 milligram use anymore because of the safer blood thinners that are on the market. So 81 milligram is okay long-term, but a 325 milligram aspirin long-term is not, unless the doctor is closely monitoring other problems. Going back to what we said before, the best use of anti-inflammatories, even if the patient has chronic pain, is trying our best to not have to use those medications daily and only when needed. We also have some topical options now, Voltaren gel, things like that work on arthritis that used to only be prescription, that are available over the counter now. Using those, even though there's still a little bit of absorption of that medicine, still less risk using that daily than possibly using an oral medicine for inflammation daily. So again, tough line to walk. And as long as we are monitoring patients and working closely with their doctor, then generally could be safe as long as we're keeping that reasonable. Had a question in the chat: does Ambien cause memory loss? Yes, there is some. It's not necessarily a given. Definitely have been some reports on that. And honestly, I would also take it a step further to say that it could be Ambien, but also in conjunction with other medicines that have a central nervous system depressing effect. There is definitely some potential there. And sometimes we've seen when you take away some of those medicines, all of a sudden that improves, things like that. So very good question from the chat. Does Ambien cause memory loss? It could. So always try to use it only in the most extreme circumstances and only as needed for the insomnia. All right, so let's talk through, before I go, that was a lot of information there. So any questions from anyone in the chat or verbally before I go on to the adherence side? This is more the safety side, where I figured we would probably spend a good chunk of our time today. All right. Well, if so, just I'm happy to answer at the end or come back, and I want to make sure I leave plenty of time for Q&A. Since I sell drugs for a living, happy to answer any questions that you guys have any time that we can help you. All right. So one of my favorite quotes was Dr. C. Everett Koop: medications don't work in patients who don't take them. So we're going to talk through medication adherence. And this is something that I know is a frustrating part of caregiving, but also a frustrating part of patient care, where it's like, hey, we give you a prescription, just take the medicine. And, unless you've, and I have to get on pharmacists and physicians sometimes when I hear this, it's like, well, just take your medicine. Well, unless they've had to actually manage 15 meds or 10 meds or whatever, it's hard to have perspective there, proper perspective in helping patients manage their medicine. I take a few, and it's tough for me sometimes to remember those medicines. So we're going to talk through what are some of the tips and tricks that might work to help improve medication adherence. But I want the big take home point here to be that taking the medicine regularly is a key factor in keeping patients independent. We have seen time and again where medication non-adherence or medication, I'll say misadherence or misuse, has led to patients not being able to remain in their home. So my job as a pharmacist and as the owner of a home care business is to try to find solutions and try to find tips and tricks for the caregivers to help our clients, to help our patients remember to take their medicine, and what are some of the things that we do there. But I'm going to say that the big two takeaway points that I'm going to talk through: taking medicine regularly, keep a key factor, staying independent, but also having a system. And I'm a systems guy. I love systems. Having a system in place to manage medicines is key. It doesn't have to be anything fancy. We've got some fancy options for patients, but really just talking through where the medication fits into the routine is really going to be really, really important. So working medications into the routine is key. What I always tell patients is, okay, when it comes to medicines, when it comes to your daily routine, what are some things that absolutely positively have to happen every day? Okay. If you're like me, you have to have coffee. I have to have coffee in the morning. That is with no coffee is a non-starter, if that makes sense. So the coffee is set up the night. I have set up the coffee the night before. I want the coffee to be brewing as I wake up. And so I would, if it was me, my thing is, okay, if I'm going to make coffee every morning, then I need to have my morning medicine sitting right next to the coffee maker, so that I cannot overlook those while I'm making my coffee. I have to take them. If they're medications that have to be taken with food, then that's fine. At least they're right there in the area where your morning routine is. Going to the evening routine, or if it's a medication with meals, positioning those medicines in a place where you are not going to forget them and making them part of your routine. But if you leave them in the restroom, okay, or whatever, and you have to remember in the morning to get those medicines, and you may not be in the restroom. I mean, you're getting ready in the morning, but it may not be the same routine that you have in the evening. It's very easy to miss doses. So setting up a planner, which I'm going to talk through in just a second, having those things in place for you, or having those things in place for the patient as part of their routine is key. So again, putting morning medicines by coffee or toothbrush, anything else that's part of your routine. And I think one of the things we have to remember is this, and even a few missed doses of medicine can have major, major effects. Okay. And at the risk of boring you to tears with physiology and pharmacology, I'm just going to keep it as simple as I can to say that your body depends on, if you're taking a medicine, no matter what medicine it is, antibiotics, blood pressure, anything, your body only can use that medicine effectively if it's at what's called a steady state or an effective level in your body. So when you take medicine, some medicines work, hey, first dose, boom. But other medicines, think like medicines like Prozac and Lexapro, which are helping with depression and anxiety, those medicines actually don't work right away. You have to take them for several weeks, really, for them to build up effective levels in the blood. So if you miss a few doses, that puts you behind getting your body's medicines to the effective steady state, and then they're less effective. So if you're taking a medicine for cholesterol, but you only remember to take that medicine 75% of the time or less, or you might as well not be taking anything almost, because that medicine will not stay at a steady state, will not stay at an effective level in the body to be constantly working. So it's not a one and done thing. I get this question a lot. Hey, my blood pressure was fine this morning, so I skipped it. Now, there are some times where we would actually say to skip certain medicines. Okay. Not often, but it does happen. If certain levels are if your pressure is bottoming out and your pulse is in the 50s, then we probably don't want you taking your atenolol or metoprolol, and your doctor needs to adjust your dose. But typically though, even if your blood pressure is normal, because we get this a lot, my pressure or my blood sugar was normal this morning, so I just skipped my medicine. And most medicines are not working that fast. Most medicines are working, but some of them are, like I mentioned earlier, atenolol and some of those medicines, but others aren't. So you have to keep that steady state up, even if your pressure is normal. And sometimes the thing that I have the hardest time communicating to our clients and patients is, well, you're right. It is. Your blood pressure looked great this morning. Your blood sugar looked great this morning. However, that is the result of taking the medicine. It's the chicken and the egg thing almost. It's because you're taking your medicine regularly. That's why your pressure or blood sugar or whatever we're measuring is good. It's just so it's that key thing. So the big take home point from this is even just a couple of missed doses can have major effects because it puts us behind in the level that it needs to be at in the body to be effective, if that makes sense. Medication non-adherence. So as I mentioned, missed doses can lead to poor outcomes, even just a few missed doses. They have to remain at steady state in the body to be effective. And look, I'm gonna just level with you guys. I don't like taking medicine. I know most of our clients and patients don't like taking medicine. It's not that I don't like the drugs themselves. It's not that. I do this for a living. I know it's hard to get into the routine and have to remember to take a certain medicine at certain times and things like that. Any change to the routine for me is tough. And so I'm not a big fan of taking medicine, but I know I have to in order to get to the outcomes that my doctor and I have set for different health goals that we have. So again, just reiterating this point that poor outcomes can happen even from just a few doses, missed doses, and medicines must remain at a steady state in the body to be effective. And let me also add to this too, that I'm hoping all of you have great relationships with not only your pharmacist, but a physician as well. This really should be a collaboration between everybody. If you're having adverse effects or side effects, kind of maybe having the pharmacist triage it to see if it's something that, hey, may need to mention this to the doctor to try to see if there's something else we can do that's effective or some other medicine that's like it. But unfortunately, what happens a lot of times is if we experience adverse effects, our patients sometimes will start taking it, have a side effect, and be like, I'm just not going to take it. And then they don't tell the doctor. 6 months later, they go in for lab work, and all of a sudden, their cholesterol is sky high, or their A1C or blood sugar is sky high. It's like, what happened? I gave you that new medicine. Yeah, I just didn't take it. I just didn't like it. Or what I call the flossing approach. You guys are laugh at this. I have seen this where we've had this does spur some conversations with our patients where they've clearly not been taking their medicine. We can see it from their refill history, but all of a sudden it's getting close to a doctor's visit, and so they got to refill their medicine and start taking it before they go to the doctor. So it looks like they've been taking it. I call it the flossing thing because a lot of us, and I'm ashamed to admit it, it's me too sometimes, is that sometimes if we're going to the dentist, all of a sudden it's like cramming for a test for the last few days before the visit. We need to make it look like we've been flossing the whole time, but we've not been flossing. Let's be real. So anyway, we see that a lot. And again, it almost does no good to start it and only be taking it for a few weeks prior to getting lab work done, because it's not going to have the effect that the doctor wants to have. So again, non-adherence and adherence, both big pieces about keeping our patients independent. If we're non-adherent to medicines and we have a stroke or a heart attack, and all of a sudden now we're in a different state, sometimes debilitating state, where we have to leave our current care model and go to a higher level of care. And again, there's other factors here. It's not just medicines, but a lot of times medication non-adherence is a big part of that. Of being able to prevent heart attack and stroke and keep our cholesterol levels down and to keep our blood sugar down. If we're non-adherent, then and we have to, experience some complication of that, unfortunately does lead to that leaving the independent level of care that we want our patients to remain within. All right, medication overuse. So I want to clarify this, is that misuse or overuse is different than abuse. We're not talking about medication abuse here. Now, with abuse, that's bad as well. If someone is overtaking their anxiety medicine on purpose, if someone is misusing pain medicine on purpose, that's a different story. Okay, we're not necessarily talking about that. We're talking about, and that's bad as well, obviously, and would lead to possibly a not being able to remain independent if they're overusing their medicine on purpose. But what I'm focusing on here is the misuse and overuse that's different than abuse. Okay. So accidentally taking too much medicine based on a poor medicine taking routine. So, in other words, if they don't have a system in place to remember, did I take my medicine this morning? Like I'll just tell you as an example, this morning I gave my 12-year-old son his medicine with his breakfast, but got busy and started doing other things. And I had a moment of doubt where I'm like, Joseph, did I give you your medicine? Did I? And he said, yeah. But those are just things that happen in our routine and daily. Did I take my medicine? And all of a sudden you may not remember you took your medicine, and then you take another dose. One or two of those probably going to be okay. But if it's a chronic issue, and we've actually seen this, unfortunately, on the pharmacy side and the dispensing side, the first sign that we see this is medications. We're not talking about abused medications, but again, medicines like blood pressure medicine and others that are running out really early. And it's like, we need to have a conversation about your medication taking routine. We know we gave you 30 days or 90 days or whatever, but if you're out of medicine now, I'm wondering if they either have a misunderstanding of how to take it, or maybe they're forgetting that they take that medicine, or they've taken that medicine already and they just go ahead and take a second dose. So again, that is also a big problem in remaining independent, because as we talked about earlier, even if those meds aren't on the beers list, if you're overtaking medicine that's not suited for your body, that you're taking a dose that's too high and your pressure is bottoming out or your blood sugar is bottoming out, and all of a sudden those could also lead to falls and things like that as well. So having a system in place also prevents medication overuse, making sure that they're not accidentally taking even just, again, 2 blood pressures, 2 blood sugars, medicines, things like that. So having a system in place. I've seen simple systems from, taking medicine out of the bottle and turning that bottle upside down to show that you've already taken that medicine and you have. And then also just having packaging or a robotic system that dispenses medicines to patients. We've seen that as well. So having that system in place, not only remember taking medicine, but also prevent the potential of overusing or overtaking medicine. But we do see this as well. And lastly, duplicate therapies. This is a big deal. And we see this at least 3 or 4 times a week, where a physician discharges someone from the hospital, or if a patient may have seen a specialist and they wrote a new prescription for them. And even if the doctor knew the other medicines they were taking, it may not have effectively communicated to the patient or the caregiver, hey, this is going to replace this medicine. You need to stop this medicine that you're already on and take this new one that I'm writing you. Or this is the bigger one we see, is when they're being discharged from a hospital or a rehab facility, especially, and their therapies have changed. And they didn't necessarily change therapies because they couldn't tolerate the others, but it could be what's called a formulary issue. In other words, you may be on simvastatin at home, but if you get admitted to a hospital or a rehab facility, they may not have simvastatin on their formulary. You may be changed to atorvastatin. And so the question then becomes, does the patient, when they get discharged, do they stay on atorvastatin or do they go back to simvastatin? And so this is where what we call medication reconciliation, which I'll talk about that in a second, is so critically important. And having that relationship with a pharmacist, but also that the doctor has all the information from discharge. That's so, so important. So my biggest tip, if you are hospitalized or you are discharged from a rehab or short-term stay somewhere, you've got to see the doctor within 7. I know this is a tall order, within 7 to 10 days of being discharged, because we've got to see what's the new therapeutic plan. Are we going back to the old therapeutic plan? Are there medicines that have been stopped? Sometimes at discharge, those things are communicated very, very well, but that's fine. But what happens when those medicines run out? Or what happens in rehab when you're discharged with those medicine cards, but you run out in 5 to 10 days, and the doctor, your regular doctor, has no idea that they started you on those medicines. So the biggest thing I say, as soon as I hear, hey, mom or dad got out of rehab, okay, great. When's the doctor's appointment? Oh, we don't have one. Okay, we've got to make one today. this is an urgent matter. And if they say, well, they don't have any open appointments till then, call them back, because now they've started you on medicine and they never get discharged with refills on those medicines when they're at rehab ever. And long-term care pharmacies will never transfer prescriptions to retail pharmacies. They just won't do it because there's usually no refills on them anyway. So they've got to see, okay, which medicines are we continuing? So duplicate therapies or therapeutic duplications like that can cause issues for patients when two medicines are prescribed by different providers that function the same way. And when we say function the same way, you may be on multiple blood pressure or cholesterol medicines. We're talking about blood pressure or cholesterol medicines in the same class of medicine, like simvastatin and atorvastatin, or lisinopril and fosaprepitant, or medicines like that. Okay. If you're being discharged, we want to make sure you don't go home and then are taking the new medicine along with the old medicine. So very common after hospitalizations, skilled nursing facility, or short-term rehab stays. This is why our business, and one of the reasons I wanted to do this business was to help with medication reconciliation in the home, especially after a hospitalization or rehab stay. Make sure all providers have an updated list of medicines. I cannot emphasize this enough. Even if it's something as simple as an index card or something as elaborate as an app on a smartphone, you've got to have an updated list for your person that you care for, an updated list of their medicines at all times. Making sure because we've seen old ones, and then if they get admitted to the hospital and then they have an old list, perhaps they may be started on all of these old medicines in the hospital. That we actually saw this. This is a quick story. We had a patient who unfortunately got admitted for a psych evaluation and needed to be in there for some time. But there were no psych beds in the Birmingham area. They got admitted into a facility somewhere in East Alabama, and they had been in that facility before. It's been several years. And so that facility had an old med list for that patient, a very old med list for that patient. And that patient did not have a current med list. And unfortunately, that facility made the assumption that the med list that they had from several years ago was still current. And so they were started on those medicines and, had to get switched back to their medicines at discharge. And when I asked the discharge planner about it, because we package medicines in these adherence packs in our pharmacy, I asked them, I said, where'd you get this? And they said, well, this is the records we had from the previous stay. And so it was a mess, and we had to clean it up with her psychiatrist and her PCP when she got out. So carry a list everywhere. Have providers reconcile medicines after a hospital or rehab stay. Your pharmacist can help with this. Many times, again, discharge planners and social workers in the hospital sometimes have a really good list of which medicines we're stopping, which medicines we're starting at discharge. Ask for that. Always ask for that. And then when you leave a hospital, Lord knows you get like 50 pages of paper. Okay. But try to make sure that the stop and start med list is easily accessible so that you know what meds to stop and start, and to carry that with you to the doctor within 7 to 10 days of discharge to see, because that doctor may say, you know what, we're not going to stop that. We need to be on it for this reason. But if you don't see the doctor right away, then you won't get that medicine. So this is critically important. Even if it's something as simple as a written list or something as elaborate as an app, try to keep it as updated as possible. Utilize your pharmacist to provide a medication printout of everything you're taking, and update that as much as possible. So I want to leave it open for questions. I feel like we had a pretty good amount of content there, and that's my email address. And I do have an office number, but that's the easiest way to get a hold of me. That's my direct number. I answer it all the time. So feel free to call, text, email, whatever gets you the information to help you take care of your patients the best way possible to keep independent and aging in place. That's what I'm here for. That's my mission. So anything I can do to help, please feel free to reach out.
I had a question, Patrick.
Sure.
When, say for whatever reason, your doctor does change, your medication, and you have all this medication you're no longer using, what's the best way to dispose of that medication?
So I don't like to flush it, because especially because it's going into the water supply and sewer. Here's the thing. It's going to be patient specific, and here's why. So if there's a possibility that you could be put back on that medicine and there is a possibility you could. Keeping it separate from your other medicine somewhere else in the home that you know where it is, it's not going to get into your daily medicines is okay. So you spent money on it, whatever, I would recommend trying to keep it in the however unlikely event it is that you might be put back on it. Now, again, it's only good for so long. Once it's been dispensed from a pharmacy, we typically only say it's good for about a year. Or, well, it's not that it goes bad, it's that we can't guarantee its potency beyond a year. But if you're going to dispose of the medicine, check with your pharmacy to see if they have a medication take back program. Most pharmacies do, where they may have a standalone container in the pharmacy that you can drop off medicines to be destroyed, or the pharmacist may have a system like we do, where you can put it, we just put it in an envelope and send it off to be destroyed, or our pickup company comes and gets it. Because we work with a lot of facilities and a lot of those med packages, if someone, if they pass away or whatever, or there's medication changes, then we destroy the medicine that's been changed if there's no help, no, possibility of them going back on it. So the short answer to that question is I would start with the pharmacy to see if your pharmacy has a take back program. If not, the health department sometimes does. And there's usually events a few times a year, especially Earth Day. Earth Day, I promise you, in Earth Day, there's going to be a take back day somewhere around your area, whether it's at a pharmacy or at a police station. Sometimes the police department, because they obviously want to make sure we keep narcotics and controlled substances out of the wrong hands. We'll host medication take back days, or the DEA will, in conjunction with those. So looking online to see where those are, but I would start with the pharmacy before you flush them or throw them away. Let's start there. There's also some systems in place that actually do dissolve medicines. There's some systems that can be purchased. They're a little expensive. But I would always look for the take back days or the pharmacy to take it back first. Good question.
Right. Thank you so much. And Brenda had a question about, she says, can you speak on medications for dementia and how they are prescribed?
Yes, absolutely. We got to break it up into two different, we have medications that are used for prevention of progression of Alzheimer's and dementia, and then medicines that are sometimes prescribed for the symptoms. Okay. So, if we're using, we talked about antipsychotics earlier, like risperidone and quetiapine, and those are medicines that can be used in dementia, but only for not necessarily to treat the dementia, but to treat some of at a low dose, to maybe treat some of the symptoms if the patient is prone to hallucinations and things like that. Typically, antipsychotics are not utilized in dementia unless we've got some hallucinations. This is different than some of you may be familiar with sundowners and things like that. We typically don't even use antipsychotics in that. We typically use trazodone and things like that are a little bit safer. But to answer your question, Brenda, for how they are prescribed, usually what we see is we see medications, Alzheimer's and dementia, kind of grouped together in terms of that. And the main goal that we have in using medicines to treat anything cognitive like that is we want to prevent the progression. Okay. I will tell you that there's not a medicine that I'm aware of that does any kind of reversal, but our therapeutic goal in medications for dementia is to try to trap it where it is and try to hopefully get it to where it won't progress. And a lot of times it still will, but a lot of times we will use medications for memory like donepezil and memantine, other medications like rivastigmine and things like that are used to hopefully slow the progression of that. And how they're prescribed is how it's supposed to be prescribed, is prescribed at the lowest effective doses first. So for someone on donepezil, we would usually start them at 5 milligrams a day for 30 days, and then go up to 10 milligrams a day after that. And then we may titrate back down if they're having side effects. But we want to try to find the lowest effective dose. Memantine or Namenda, typically 5 milligrams twice a day to start, and then going up to 10 milligrams twice a day beyond that. But I will say that once you've reached 10 milligrams a day of donepezil and 10 milligrams twice a day of memantine, there's not much more that can be added, at least on those medicines. I would not recommend going higher than that on those. I've seen a couple of people on donepezil higher than that, like a 10 milligram twice a day. I don't think you're getting any more benefit than if you were taking the lower effective dose, the safer dose. So to answer your question, it's a lot of symptom specific, but it's also let's try to find the lowest effective dose. And those medicines are medicines that take a while to work. So we've got to let them build up levels in the blood to be effective. You're not going to see positive effects of those medicines day 1 or maybe even day 14. Probably would be closer to day 30 before you really start to see an effect if those medicines are hopefully slowing the progression down of the dementia.
Thank you.
So, Patrick, quick question. That everybody's taking the Prevagen. And
Yes.
then if you were doing that on elderly people, do you think that's effective?
The short answer, what I give to people is Prevagen is not shown to be harmful. And there have been some, they're not peer reviewed. I always like when I look at a study or something, like, is it peer reviewed, double blind, all these things I usually would take into account as a physician would as well. But the case reports from it show at least the case reports have been somewhat positive, but there's not really a study out there that shows taking this against a placebo is effective. That's what we typically look at in medicine. So the short answer for Prevagen is there's no risk right now. There's no published risk of harm, but there's not really been a vetted study that it's effective. But I don't see the harm in taking it. And there are some people who swear by it. We do sell it at our pharmacy, especially when it comes to short-term recall. Long-term recall, I don't think is effective, but I think there is some data, not studies, but data showing that the short-term recall is good or is improved. And we have patients that swear it is as well. I don't know how much of it is the actual active drug. Those of you that may not be familiar with Prevagen, it's actually made from jellyfish. I know that sounds weird, but they are made from jellyfish. Some of the secretions and things like that are within their skin. So kind of weird, but not harmful necessarily. So I think that Prevagen, and there's even supplements like ginkgo biloba and things like that, while they've not been vetted out like many traditional medications have, there's not a ton of harm risk there. And if it is helping, and it can, we've seen patients that say it does, then I don't see the harm in necessarily taking it. Now with ginkgo and Prevagen, if they're on blood thinners, let's have a conversation about it prior. There's not a whole lot of studies with it in blood thinners. And when I say blood thinners, I'm really talking more Coumadin, not necessarily Eliquis or Plavix. Always caution about blood thinners with herbals, which I would consider Prevagen to be as well.
Okay, thank you.
I think Angela said something. What are the effects of taking pain meds in older adults? What pain meds older adults avoid? Oh, this is a tough one because just like with medications for dementia, we want to keep pain management at the lowest effective dose. Believe it or not, there are long-acting medicines. Some of the medications are actually somewhat safer in adults. Now, I would avoid Tylenol with codeine. Codeine can stay in the body a good long time. Hydrocodone, even though it's metabolized into codeine, still doesn't last quite as long in our older adults. And so I would say the lowest effective dose of hydrocodone, taking into account the other medicines they're taking, trying to keep it limited to hydrocodone. Once you get into oxycodone and some of those others, we are a little bit more worried about drowsiness and dizziness. But believe it or not, even in older adults, those medicines don't hang out much longer. Unlike medicines like Valium and things like that have these nasty metabolites, they don't necessarily do it. So, but codeine does. So Tylenol with codeine I would avoid. And that's tramadol. I'm not a big fan of tramadol because of its effect on other things in the body, serotonin, but it's safe. It's a lot of times, a lot of doctors like to use it because it's less habit forming than hydrocodone. But if possible, the lowest effective dose of hydrocodone is I would do that ahead of tramadol in someone who's older. And if you have, and not that hopefully no one does, if anybody has any extra Darvocet laying around the house from years ago, which we had a lovely patient, Miss Warren, for years, who when they pulled Darvocet off the market, it's pain medicine. It had some heart effects. She called me and said, Patrick, I've been taking Darvocet every day since like 1964. Just one tablet a day. Is it going to hurt me to keep taking it? And she's like 95 years old at this time. And I'm like, Miss Warren, I think that's your call, but probably not. But, again, Darvocet, if it was still on the market, I would say absolutely not in older adults, especially on a regular basis. So.
Patrick, I had to take my mom to the ER one time because she was having leg pain, and they say it was caused by the problem in her back. She has low back pain.
Mm-hmm.
And in the ER, she was like screaming because she was in so much pain, and they wanted to give her a shot of morphine.
Okay.
And I said, no. Can you talk about the effect of morphine?
Yeah. Morphine as well, different than hydrocodone because it does last a little bit longer. I do caution with morphine. It's still usable in older adults, but at the same time, we also want to make sure that we're using the lowest effective dose possible. Morphine can cause respiratory depression. All pain medicines can slow down breathing and cause respiratory depression. So anytime we can avoid it is fine. And pain is so tough to treat because they're trying to find that balance between what's harmful and what's going to give her the effect. And they're assessing her pain level based on the fact that her, she's screaming in pain, but I will say that morphine's the fastest acting. And if she's going to be in the emergency room for a period of time and not just going straight home, the lowest effective dose of morphine, if she's going to be monitored, is okay. But I get concerned about long-term use of it, especially since it lasts a little bit longer. It does have some metabolites that stay around longer and things like that.
Okay. Thank you.
I didn't talk about gabapentin and Lyrica. I know a lot of our folks are on that. Those are not on the beers list, but again, those are medicines that do work on that type of pain that you're talking about, that nerve-related pain that a lot of times are used in lower back pain, nerve issues. And those do have a risk as well. They're not on the beers list. They're not on that list, but they do have a risk of drowsiness and falls. And so anytime we can use the lowest effective dose of that as well, very important. And that's really those are the only medicines that really work on nerve pain. There's a few off-label uses of like duloxetine and venlafaxine that are actually antidepressants, but sometimes are used for nerve pain. Certain seizure medicines are used for nerve pain, but gabapentin and Lyrica are probably the most, or pregabalin's the generic name for Lyrica, probably the most common, but those still have a risk as well.
Okay, thank you.
Well, Patrick, thank you so much for this
no problem.
informative presentation. We truly appreciate it. And it's great information. I took a lot of notes to share with my mom. And so and we're recording it too, so we can share it with others that way as well. But thank you so much. And thank you for sharing your contact information. So if our caregivers have any more questions, they can follow up with you. We appreciate that.
Sure thing.
Thank you. So everybody, we will send our post-event survey to you today. Be sure and fill that out, and we will see you again soon. Thank you all for joining us. Have a great day.
Thank you.
Thanks, guys.
Bye.